Welcome to Arthritis at Home. I'm Maya, and I'm the program coordinator at Arthritis Consumer Experts. It is my pleasure to welcome Graeme Reed to our program today. Graeme recently collaborated with ACE to produce the fall issue of JointHealth Insight. The issue examined the impacts of structural racism on the health outcomes of Indigenous peoples in Canada, and we thought it would be really valuable to continue that conversation here today. Thank you so much for joining us today, Graeme, and would you mind just introducing yourself to begin with?
Yeah, miigwech Maya, so Anim Bojo, Graeme Reed, Anishinaabe, Ottawa, Nunjaba, Anishinaabe, and Dao. It's an honor to join you from Musqueam, Squamish, and Tsleil-Waututh lands. I'm the current chair of the board for the Canadian Spondylitis Association, and I'm a member of the Integrated Science and Medical Advisory Body for the Arthritis Society.
Thank you. I am hoping that you can cover what you think are the key inequities experienced by Indigenous peoples living with arthritis.
Yeah, great question. And it was as you said, a difficult one to answer, but I think the starting point to this is just the acknowledgement that this isn't a question about whether racism exists. It's a question and an assertion that, systemic racism is everywhere in our healthcare system and negatively impacts Indigenous peoples and not only their access to healthcare, but also their health outcomes. And, in the article, we discussed a variety of kind of different things that manifest from, a history of colonization that, have forcibly put First Nations into residential schools that have a wide swath of medical testing and approaches, the latest of those schools being closed in 96, several years after I was born. And that kind of like colonial practice and approaches and negative assumptions towards Indigenous peoples now manifests within the kind of systemic racism that we see, and that is, recorded and kind of broadcast on national and international media. One example that we pointed out in the piece was the murder of Joyce Echaquan in a hospital. And this unfortunately is not a news story, but, the kind of disproportionate access to, arthritis care, both kind of from the primary healthcare perspective, but also the specialist healthcare is something that's kind of rampant within the system. In the article, we also discussed the NIHB ranking on the different kind of provincial scales. That is, the non-insured health benefits that First Nations often access to get access to their, medical treatments and services. And it's regularly rated at the bottom. And, I think that's a really just good example of these systemic barriers that prevent Indigenous peoples from accessing kind of equitable arthritis healthcare and services.
These things are not unique to Indigenous populations in Canada, but disparities in arthritis are experienced in a number of different settler colonial nations, including New Zealand, Australia, and the US. And I think that really speaks to what you're saying about how these are functions of colonialism and they're not unique to Canada. I think as we put it in the article, they are not by chance. So.
Yeah. And they're not unique to one jurisdiction. I gave an example of what happens in Quebec, but we could find multiple examples across every single province and territory, and federal services, right? On reserve, part of accessing healthcare services is kind of navigating the intersecting jurisdictions of healthcare, whether provincial or federal, and that creates that kind of additional burden on individual First Nations citizens to access care and to kind of seek the payment required to do that.
For non-Indigenous listeners who are people living with inflammatory arthritis, I'm sure that you are all aware, as Graeme and I are ourselves, of how difficult it is to actually navigate these things, even when we have the really simple, easy access through our provincially covered medication and healthcare systems. And even then, it's so difficult to figure out how to actually get coverage for things and coordinating things with your patient support program and with your provincial drug plan, your pharmacy, etc. And so just to really think about the added complexities when there is so much more, there's such a lack of clarity for how to actually go about navigating these things as an Indigenous person on reserve, I believe, or off reserve.
Yeah. And just to say, like, I think, part of the kind of broader frame of writing this piece was recognizing the kind of positions of privilege that many of us in the arthritis community experience, right? Like I live with both ankylosing spondylitis and Crohn's. I have what I kind of like loosely refer to as this like nexus of, healthcare professionals that, essentially I need to navigate to, and between, the gastroenterologist, my rheumatologist, my dermatologist, like all these things that, require additional time and space and capacity to do that. And if we're talking about, Indigenous peoples that already face this kind of structural oppression from the kind of legacies of colonial system that, massively disrupted their life ways, that's just put on top of that. And then when, participating in those systems, the amount of kind of, systemic racism and discrimination and negative assumptions that they face then translates to even more challenges and barriers. And so, I think it's kind of incumbent on us to also recognize, our kind of reflexive position in this and how we can open up space for others.
Graeme, something you said earlier was about how discrimination in healthcare is experienced all across Canada. There was recently a report that was released. It was an independent investigation into Indigenous-specific discrimination in BC healthcare. It was led by Mary Ellen Turpel-Lafond, and it uncovered some pretty disturbing findings. So I'm wondering if you can speak to what findings stood out to you the most.
I think like quite appropriately, the approach that she did was in a really good way and kind of acknowledged the kind of content warning that was required for the reports that she circulated. They spoke to over 9,000 people in a pretty short window that kind of unearthed. It was originally triggered in response for the game that was being played around guessing, Indigenous patients' blood alcohol levels, that then kind of snowballed into the unearthing of, the essential kind of systemic racism and discrimination that, First Nations and Métis and Inuit in BC face at the point of care. And I felt like, it was probably for me one of the best articulations of the kind of anecdotal conversations that I have regularly and that we hear within, different examples of people doing research. In our article, we talked about Dr. Cheryl Burnaby and the kind of research that she does in terms of healthcare professionals navigating racism. And I thought, Dr. Turpel-Lafond's work was, just another step in unearthing, these really really disgusting things that we often don't talk about or we like casually look away. And so I found, a few different pieces that were pretty interesting. One relates to what I was discussing earlier in terms of the access to primary care. It's interesting to think about, how all of us likely in our diagnostic journey accessed the specialists that we now have following us annually, biannually, whatever it is. And all of that was really contingent on that first point of contact. And I think, in the article, it kind of unearthed the cycle of discrimination and racism that, First Nations and Métis are facing within the BC healthcare and system. But then you could bring that broader to the kind of healthcare system across Canada that, I think really really highlighted to me the role that we play in identifying and navigating that. Um, I also found, and we tried to discuss this in our article, the kind of absence of, Indigenous health practices within the kind of healthcare system. And arguably, BC is one of the kind of more developed provinces towards Indigenous peoples. We know we identified in the article the First Nations Health Authority. We know that last year BC passed the legislation on the UN Declaration on the Rights of Indigenous Peoples, both of which kind of signal, enhanced reconciliation with Indigenous peoples living in what we now call as BC. But the fact that these systems are not treated equitably speaks to the kind of ongoing supremacy of Western science within the healthcare system that, almost, I don't know what it is, disqualifies or discredits the kind of lived experience and kind of ontological life ways that, First Nations bring to healthcare and other systems. And, I thought that was really important to unearth. That's kind of what we discussed when we're, moving from, essentially cultural violence to, cultural safety. Part of it is how do we address these kind of knowledge systems equitably? And I thought the recommendation for, the joint MD in kind of, medical science and then Indigenous science, pretty interesting, and kind of feeding off of similar degree programs. At University of Victoria, there's a joint law and Indigenous law. There are a few kind of environmental law and science kind of programs back in Ontario that I think are pretty interesting. And the final piece, so that was just kind of one recommendation, but there were 24 in total, and I encourage everybody to actually read them. They were separated into kind of three categories, systemic, beliefs and behaviors. And I think it would do well for all of us to kind of read the stories and kind of actually give truth to the concerns that we're hearing.
What can non-Indigenous arthritis patients and healthcare providers do to address these issues? I think often it can feel like we're separated from these things and, well, I don't do this, I'm not a part of this. I think it's really important to identify maybe the ways in which that is not true, or there are still things we can do.
I think that's a really important question, and something that is often asked in just kind of broader relations with Indigenous peoples. And my kind of response is kind of relates back to what Justice Murray, now Senator Murray Sinclair, and Grand Chief Willie Littlechild talked about in the Truth and Reconciliation process, which essentially said that truth comes before reconciliation. And a lot of the negative assumptions that we see manifesting in our healthcare system relate from not really understanding the history of the land that we're all on. And so part of it is really understanding the kind of like abhorrent colonial tactics that Indigenous peoples are still living, the kind of intergenerational trauma from stuff that happened not several hundred years ago, literally, as I indicated, residential school closed less than or around just over 20 years ago. We have elders and knowledge keepers and others who in their lifetime participated in residential school, all of which is, I think, important for just broader Canadian society to really understand that help, I think, kind of hopefully debunk some of those kind of negative stereotypes and assumptions having towards Indigenous peoples. I also think that part of the identification of the fact that we're, a healthcare system that is systemically racist also is kind of requiring us as, healthcare patients or doctors or allies to really kind of internalize what being anti-racist really looks like. And I thought one of the interesting findings, and Maya, you pointed this out, in the report that Dr. Turpel-Lafone prepared, was essentially that 1/3 of healthcare practitioners or professionals, witnessed some level of discrimination or racism. That tells to me that, it's no longer appropriate to just be, that, or claim that you or your, peers or whatnot are not racist. We have to be kind of actively racist. And I think, the final point that um, I think is important is to recognize that, this sort of kind of systemic level of, racism and discrimination requires systemic level action. And that really needs all of us. And in the article that we put together, we put a few resources that help do that, and help kind of reach out to your different MPs. One of the additional recommendations was to suggest like a BC Indigenous medical health officer, and starting to create kind of parallel spaces for the equitable treatment of knowledge systems and experiences. And so, that's something that all of us can do. And it's something that we can, really participate actively within our democracy, recognizing, our ability to, be active constituents, right? Voting is just the first step in active democratic participation. And so, kind of recognizing what else you can do to get these things on the table is extremely important. And then, then communicate that with others, right? I have an auntie who talks about kind of the differing concentric circles of action, starting with yourself, then your family, then your community, and then your, nation. And so I'd encourage folks to kind of think about that in the way in which they're learning about, these kind of ongoing truths that are facing Indigenous peoples and, other structurally oppressed groups. Like, we're focusing obviously on Indigenous peoples. My positionality is connected to First Nations folks, but, we know that, patients that are Black or people of color face similar levels of systemic racism. And so wanting to make sure that, those struggles for systemic level action are considered kind of as the same struggle, right? Like this needs to be in the forefront of our conversations and our responsibilities as patient associations and patients living with arthritis.
Thank you. That was so well said. And I think what stood out to me the most in everything you just said is that these system level issues require system level solutions. But we are all a part of that. We are a part of changing the system, and every single action, conversation, interaction we have every day, we have the opportunity to either reproduce racist ideologies, whether against Indigenous peoples or Black folks or any group of people who are visible minorities or disadvantaged. We either are going to reproduce those things or we have the opportunity to oppose them. There are ways that you can take more of an active role. You can reach out to your MPs or MLAs. We are actually going to provide after this interview just some resources for some more learning. And also just to reiterate what Graeme said is that just it's really important for us to have an understanding of basic colonial history in Canada, to understand what has transpired and continues to transpire, because that is really foundational for our learning and allyship and to support Indigenous peoples in our community. Graeme, is there anything else that you'd like to touch on or say before we let you go?
No, I appreciate the creation of this space that ACE has embarked on, and the CSA is equally interested in that, and I kind of call on our other allies to kind of walk with us in this journey, because it's as you kind of indicated, it requires all of us to do that, and together we're stronger. So yeah, Chimigwech for this opportunity.
Thank you, Graeme. And on behalf of the ACE team, we're so grateful for your guidance and support with bringing this topic to the broader patient community, and most importantly, to doing what we can to address this. To our viewers, thank you so much for tuning in. Please feel free to leave any feedback that you have on social media, or you can email us at feedback@jointhealth.org. And we do really encourage you to check out these resources that will be posted right after the video. Thank you.